it would be even better, but it's already okay like this.
Okay.
Okay, great.
Okay. Okay. Today's my topic of presentation is cardiac dysfunction, and it's very important topic in BMT patients as well. Today, my objective of my presentation are introduction, causes, clinical presentation, and nursing. And so, cardiac dysfunction and cardiovascular diseases, CVD is the broad term covering disorder of the heart and blood vessels, including hypertension, coronary heart diseases, cardiovascular diseases, peripheral vascular diseases, heart failure, rheumatic heart disease, congenital heart disease, and cardiomyopathies, according to World Health Act in 2017. This is the general definition of the cardiovascular diseases. CVD is the common. The World Health Organization estimate that the more than 17.5 million people died of the CVD, such as the heart attack or stroke in 2012, representing 30% of the all global deaths. And CVDs are the number one causes of the death globally. As long as my concern, and I am working in the hematology oncology BMT unit, I would like to talk more about the cardiovascular dysfunction in the BMT patient. Causes of the cardiac dysfunction in BMT patients could be in pre-HSCT, HSCT, and post-HSCT. Pre-HSCT cardiac issues due to the chemotherapy, radiation, pre-existing cardiac diseases, and in the HSCT, as the hematopoietic stem cell transplantation have a lot of complication as well. So cardiac dysfunction is one of them. And the post-HSCT, obesity, hypertension, vascular diseases, and chronic GVHD. And in the pre-HSCT, there could be the direct injury and hypertension, other underlying cardiac diseases, and other cardiovascular risk factors. And radiation, high doses of cyclophosphamide and other chemotherapy could be a cause, and it could be the cause of direct injury of the heart as well. And hypertension, metabolic syndrome, immunosuppressive medication, and tyrosine kinase inhibitors. And as long as my colleague Sandeep have already discussed in his presentation that the renal dysfunction is also due to the hypertension as well. Other underlying cardiac diseases due to iron overload and Hurler syndrome, sickle cell, and cardiomyopathies. And other cardiovascular risk factors could be diabetes mellitus, metabolic syndrome, and dyslipidemia, and sarcopenia, obesity, and GVHD. And in HSCT, conditioning regime associated with the cardiovascular toxicity, and cyclophosphamide cause congestive heart failure, hemorrhagic myocarditis, and pericarditis. And cyclosporine also causes the hypertension. And another causes seen in the BMT patient is the hypomagnesemia as well. Post-HSCT common transplant complication could be thrombotic microangiopathy, and associated cardiovascular complications, the systemic hypertension, pulmonary hypertension, and the pericardial effusions. And it could be due to sepsis and systolic dysfunction, myocardial depression, and the decay. Hepatovenous diseases and the fluid over leading to the decompensated heart failure. Post-HSCT due to high doses of cyclophosphamide has been implicated in both acute and chronic dysfunction of the HSCT. and pericardial effusion and pulmonary hypertension are detected earlier after HSCT and can cause the significant morbidity due to the CSA and the hypomagnesemia. Chronic versus host diseases, GVHT, and post BMT patient. In clinical presentation, it could be a bradycardia, tachycardia, and cyanosis, pedial edema, raised GVC, and basal cleft, pulmonary edema, and kinetic apnea. Prevention of cardiac dysfunction. It could be early. Prevention of the vascular disease in thalassemia primarily consists of the properly controlled transition therapy and iron chelation. And supplementary may be affected. Iron chelation therapy should be aimed at the controlling non-transfusion bounded iron, lowering the mitochondrial oxidative stress and defloxacin and the defecation improve the endothelial function over time. Nursing management. Patient can present at any stage of the transplant. Nurse will play the pivotal role in its detection. Vital signs taken by the nursing staff can alarm the physician on floor about the cardiac rates, and strict vitals monitoring, including blood pressure, pulse rate, and rhythm, must be noted, and cyanosis central and the peripheral are advised. Look for the pedial edema or facial puffiness of the patient. And based upon the symptom of the patient at the following workup should be done efficiently. ECG and chest X-ray, cardiac enzyme, baseline labs, echocardiography. And ECG, as the nursing staff must be know the how to do ECG, and about they must be know about the leads, and they must know about the paper as well in the ECG machine, and that they could be do ECG efficiently, and they must be know about the ECG that they could discuss with the physician as well. And hypertension in the general population defined as the systolic BP more than 140, and diastolic is more than 90. And mean as the systolic BP is 135 or diastolic is more than 85. Hypertension in the people following HSD is the 2.06 times and 95% CI 1.939 to 3.04, more likely compared with the sibling donor or the or HSCT. Nursing management of the hypertension. Stage 2 hypertension requires the immediate action, while for stage 1 hypertension, the stepwise approach, correcting contributing factor, and adjusting therapy may be sufficient. Avoid the use of the any potent short-acting agent which can cause the preparation fall of the blood pressure, such as the sublingual and nephroleprin. Blood pressure preferably should be well controlled prior to the onset of the severe pancytopenia. Administration of the various blood products and the fluid in the post-transplant period, uncontrolled pain and anxiety may be contribute to the hypertension and should be addressed by nursing staff. Hypertension contributes to the calcium inhibitor CNI associated the posterior reversible encephalopathy syndrome. Blood pressure normally start to increase within 2 to 3 days after starting CIC. Diuretics have the advantage of the short acting and first choice for the temporary hypertension, especially related to fluid overload, but are not the very effective in the controlling blood pressure due to the CNI associated the spasm and maybe causes hypokalemia and hypomagnesemia as well as the worsen renal function. In the context of the VOD, and RSOS diuretics should be used routinely in the associated with the antihypertensive measures. And ACE inhibitors are the effective, but in combination with the CNSA may be increase the kalemia and worsen renal function. Long-acting calcium channel blockers such as the endorphin are very effective in controlling blood pressure, increasing due to the vasospasm, and one of the first choice antihypertensive. In case of severe mucositis, it is the advisable to insert NG tube even under the plated cover if necessary, and use that to administer the antihypertensive. If patient is critically unwell, blood pressure are not under control with the routine antihypertensive measures, I will better with the invasive blood pressure monitoring should be considered. And screening can be provided by the variety of the clinician, medical, nursing, or the other allied professions, depending on the model of the care. If cardiovascular risk factors are detected, given the command, they can cause, they can usually be referred back to the primary care clinicians who are the more experienced and frequently manage range of the long-term condition, including hypertension, glycemia and control, and often even access to the weight management. Primary care clinicians are the familiar with the using risk assessment along with them, such as the fragmentation risk scoring. It is according to 2008, and maybe other which are the countries specific. Yes, sir. Any question?
Thank you, Azra.
Thank you, sir.
Thank you.
Thank you, Mohad.
Okay, so I just want to, well, you all know that the tool we use, BMT Plus, will automatically identify hypertension stage 1 and stage 2. These are based on, I think, the American Heart Association standards for children at different ages, and